Good morning, everybody. I'd like to welcome you all to combined surgery and anesthesia grand rounds and an in-person visiting professor after a long period of time who's sponsored by the class of 1975, the medical school class. And the goal of this visiting professorship is to bring a world-class individual with expertise in the use of simulation or education to enhance patient safety to McGill for an opportunity to hear his or her expertise, but also, and probably equally important, a chance to get to know them. And I'm really delighted this morning to introduce our class of 1975's visiting professor, Dr. Robert O'Brien from Melbourne, Australia. When I greeted you this morning, instead of saying good morning, I probably should have said good day, and please accept my apologies. Dr. O'Brien is the Executive Director for Education and Research for the Australian and New Zealand College of Anaesthetists. And his background is really quite rich as a surgical and anesthesia educator. Currently, as I mentioned, he has this role within the college, but he's also an associate professor in the Department of Critical Care at Melbourne Medical School at the University of Melbourne. He has previously directed a very large simulation center in Perth, Western Australia. He's been in charge of the main society for simulation within Australia. He's really an internationally renowned expert on education and how adult learners learn and think. And we're really honored and delighted to have him here today. But as they say on the shopping channel, not only that, not only is he a world-renowned educator, he's also a wonderful and rounded human being. He's an enthusiast for many sports, and he's worked with the Australian rules football as an educator and as a coach, and is very interested in what the aspiration for people to achieve elite performance status. And I think that this is something that is always very relevant to us as we talk a lot about competency-based education. The concept that we want to get beyond just competent, but truly aspire to greatness. We're really pleased that he's going to speak to us. After his lecture today, he's going to go visit the Institute for Health Sciences Education and then spend the afternoon at the Simulation Center. I really want to have him spend the time rather than me with the intro, and I'm really delighted to introduce Dr. Robert O'Brien.
Thanks, Jerry. That's a very big introduction to follow, and I wanted to thank you for your kind words, and thank you for hospitality that I've experienced so far here at McGill and in Montreal. I'm almost saddened, I suppose. This is my last day here, and then I have a few days off, but I'm looking forward to possibly getting back to some normal sleep, because after a week and a half, one would have expected I may have gone on to Canadian time, but it hasn't quite happened. So at the moment, it's just about time for bed, but we'll see how we go. So as Jerry said, I've been involved in simulation for quite some time. Education, I have an education background. I've worked for over 25 years in education, and the last 15 predominantly in medical education. I've worked within hospitals and universities, and kind of fell upon simulation almost by accident, and partly because I have a behavioural psychology background. So the whole idea of looking at what people do and why they do it, thinking about what may have led to something occurring, trying to make people aware of those triggers, became something that seemed to be a logical movement, I suppose, into that simulation patient safety, and then became quite interested in looking at medical error, and have sort of progressed from there. So I do currently work at the College of Anaesthetists as the Executive Director for Education and Research. So I look after all of the training program for anaesthesia. We do it quite differently, I've realised over the last few days, to Canada. We don't go directly from university into a program, as you would call it here, in that we have our students finish their medical degree. They would then do an internship, then do maybe 1 or 2 years of working within a hospital and choosing the stream in which they wish to work in, and then going into a training program. And that would be either a surgical, physician and anesthesia or critical care type pathway. And then they start their 5 years of training. So for most, it would take probably at least 7 to 8 years before they've finished their training from the time that they finish their medical degree. So we have a long time to work with them to try and bring about what we hope would be the skill set required to be a generalist anaesthetist, although in their last year of their training, they do a fellowship year, which would be a specialty type year. So when I asked Jerry what it was that he'd like me to talk about, he gave me the unfortunate situation where he said, talk about anything that you'd find that you'd like to and you'd be passionate about, which makes it, I think, quite difficult because it's always good when they tell you what they want. So I'm going to talk about decision making, and partly I think because of my experiences within hospitals and especially within in critical care, we often see that within that crisis period, and I don't know exactly how it is here, but in Australia, when there's a crisis, they call the anaesthetist, or as you would say, the anesthesiologist. They call the anaesthetist, and the anaesthetist comes and often bails out people and is able to manage airways and manage a range of different things that people are often a little bit taken aback by. So we spend a lot of time looking at crisis. We spend a lot of time looking at issues that are occurring. And one of the things that became apparent was that within training and within a crisis, the one thing that people weren't always aware of is the decisions that we make and why we make them and how that influences the stream of which we're going to go about our potential clinical treatment. And that doesn't necessarily matter if you're an intern, if you're a senior resident, or if you're an attending. So what we've been trying to work with people is to understand that voicing your thought processes, talking about your decision making, one, teaches the individuals that you're working with, but it also gives you the opportunity to reflect on your own processes as you go through. So we're going to have a bit of a look at decision making today. So I hope I've got no conflicts of interest. I do have a couple of affiliations as listed here. And what we're really hoping to do today is walk you through a bit of an understanding behind our decisions and how we make our decisions, the processes and the process that you would put in place depending on the situation that you're in. Maybe reflect on your own decision-making process. I've become acutely aware of my decision-making processes. My family has become acutely aware of my decision-making processes. Not always a good thing, but they now know why and how I make decisions. We'll think about the importance of our decision-making and perhaps understand how we make decisions that has a significant impact on our teams. And we'll talk about some examples when we go through there. So decision-making, what is it? It's a process of making choices. We're confronted with choices constantly on a daily basis. We gather information and we assess alternative resolutions. So simple example, we came in this morning, Dr. Fred asked if I'd like a cup of coffee. I had to make a decision what it was at particular coffee. He had a flat white, I had a cafe latte. Where's the benefit of it? Which one should I have? Why? What would I do? We make decisions constantly. We pull up at an intersection and we think about which direction we need to go. You innately do things that you learn and make decisions without being conscious as to how you're going to drive a car. We do that on a daily basis from a clinical perspective as well. You're confronted with situations, you gather information, you process that, and you make a decision and come up with a resolution. So we use step-by-step decision-making processes that can help us with, I wonder if I can, whoops, I was going to say try and get that out of the way, but we can't. We often go through a step-by-step process in making our decisions, and we think about what our alternatives are and the logic behind why we would do certain things. But do we have time in a crisis to think about the information? The more expert you become, the more you rely on different pieces of information. I once listened to a physician talk about how a junior doctor in an emergency department would go through a number of different things with a patient, potentially run a number of different investigations trying to work out what it was. The consultant would walk in, they would spend a couple of minutes talking to the patient. They may examine the patient quickly, turn around and give you the diagnosis. And they'd turn and say, how's that possible? And it was a matter of the pattern recognition, the time and the experience, and the information that you then realize what's important and what's not. One of the things we know, and in Australia in healthcare, one of the big problems we have is an unnecessary load around unnecessary investigations that we do. It may be the same here, but I know that in hospitals in Australia, if you ask and call for a surgical registrar or a surgeon to come and see someone, the very first thing they'll ask, have you done a CT scan? Always. So now, and I can see some people nodding here. Doesn't matter what they're asking. Have you done a CT scan? So rather than examining the patient, they'll want to examine the CT scan. So most junior doctors now will order a CT scan before they even call for a surgical consult. Sometimes they just don't need it. So people will sit and wait, whereas doctors used to be able to walk in, have a look at a range of different things, talk to a patient, examine a patient, and come up with what was usually a fairly good understanding of what was wrong with them. And they would make their decisions and talk to people about why they were making those decisions. So in a crisis, we do have time to make the decisions. We don't necessarily become conscious of the process that we're going through. So from a day-to-day, we know that our clinical work, our decision-making is really important. There was a study done at the Alfred Hospital in Melbourne in a crisis, and it was and they would have cameras mounted in the resus bays, and they recorded the resus, and they had people there that would mark up certain points at which they thought clinicians were making decisions. And then they would look at the types of decisions that they made. On average, it became apparent that a major decision was being made every 40 seconds over a period of what usually spanned from 30 to 40 minutes in a resus. And we're not necessarily conscious of this. The more you do it, the more you don't necessarily think that they're that significant a decision being made, but it happens all the time. People ask you constantly about the patients that they may have and ask you to consider how best to manage that particular patient. You talk to them, you gather some information, you make a decision. But we know that decision-making is part of making a deliberate action and informing people about how you're going to go about things. So what do we do? How do we make our decisions? There's two general types, and you may think to yourself, actually, that's the way I do it. So there's usually a rational and an intuitive style of decision-making. And they're two broad types of decisions that you would have. The rational decision-making is a model that employs a structured approach. It's orderly and it's logical. It's maybe one that we do when we have a little bit more time to work our way through things. It's a sequence of steps that goes through and identifies the problem or a situation, and they go through and you compile facts. You put things together, you look at the situation, and you make your decision. So it is that compilation of the investigations. It's looking at the hard data. Medicine is evidence-based, which is why medical education causes a massive conundrum for some, because it's really difficult to measure the impact of medical education. But it isn't so difficult to measure the impact of a clinical research project and a randomized control trial. So we look at the decisions, we look at the information that's been gathered, and then we make decisions, we analyze it, and we make a decision. That's my style of decision-making. I know that. People at work know that I'm a big facts and figures type person. When we're after information, I'll compile it. I'll ask them to compile it and give it to me. I'll think about it. They may not always get an answer straight away, but I'll try to make an informed evidence-based decision. An intuitive decision is more subjective in the way it finds its solution. It employs that gut feeling. I had a conversation late last night, our time, about something back in Melbourne, and someone said they've told me that they want to go ahead with it because they think it's just right. They've got a good gut feeling about it. And I went, oh, great. And so did the other person on the end of the call that I was having. And he said, I've now asked them a number of questions that they need to answer because they have to justify whether or not we're going to go ahead with this. It's the gut feeling. It's making a judgment when you're not quite sure, but you think it's the right thing to do and you have to work your way through it. It takes into account the clinician's values, ethics, emotions, and their past experience. So I've done it this way once before. It's worked out okay. And I think this is what I'm going to do again. A great example of that is an emergency physician that I worked with at St. Vincent's. When we first started to have ice, the drug, come into Melbourne, we found that people were coming into the emergency department and very low oxygen saturation levels. So they would assume that the most logical thing to do was to actually intubate and put a tube into the patient. They then found it really difficult to get the patient off the tube when they were in, after they're coming out of ICU. He one day decided that rather than tube the patient straight away, he would just ask the resident to stand there and bag the patient for a while. And he found that over time, if you continued to saturate oxygen, keep the oxygen saturations up to a reasonable level and work on the patient started to come around and start to increase their conscious level. He didn't necessarily explain this to anyone. It was his theory. He had a bit of a gut feeling and he'd done it. So when patients started to come in, and we had an increasing number of patients coming in, that was his pathway for treating patients in that situation. But it wasn't until someone finally asked him why he was doing it that he was able to talk about his past experiences. And it really was a gut feeling that he had that proved to be right. There were no evidence-based research papers on it. He didn't write it up, but it worked out to be the right pathway to take. So he undertook his intuitive decision-making processes. We also have heuristic decision-making. So this is part of our intuitive decision. So it's based on an intuitive model where 3 subcategories can be defined as shortcuts when you don't have a lot of time. So we have representative heuristics, which means that we make decisions based on what appears familiar. So you walk into a room, you see something, you talk to an adolescent who complain, or a middle-aged female who's complaining of upper abdomen pain and right quarter, has complained about this pain for the last couple of days, has come on in more acute levels in the last few days. She's had a range of different symptoms and I think it could be a gallbladder, okay? Because it seems like it's the most appropriate, the most familiar thing. An anchor heuristic uses a value system to quickly devise a solution in an emergency situation. So you anchor yourself on something and you just make your decision and work out what your solution could be. The availability heuristic relies on memory and past experiences along with known facts to reach the decision. So it is your past experiences. So all your intuitive gut feelings are actually based on a system anyway. And it's usually based on what you've done in the past, what you're looking at. One of the big issues that you often have with either of the 2 systems, that will either be the intuitive or the rational, is bias. Because we often collect data to try and reaffirm our position, or we'll collect data with an intuitive type one to reaffirm that gut instinct to make sure that we're right. And then we'll try and justify it to people. And that's why voicing and explaining your decision-making processes to people is really important, because it has the opportunity to try and minimize. I think it's very difficult to eliminate, but to minimize bias that we could experience. So when we go through our recognition primed intuitive type process, we think about the patterns and we mentally weigh them up. So if you think back to medical school, and I know in Melbourne, we teach patterns. We teach pattern recognition. We talk about anatomy, physiology, the sciences. Sorry? Oh, thank you. There we go. Perfect. Thank you. We teach students to understand the sciences and then put the patterns together. So we are really teaching them about recognition primed decision-making processes. And you go through and have that whole pattern recognition, which is really what you rely on very early days in any skill that you're learning. When we try to teach skills back or try to teach information back and you're expert level, we don't necessarily provide people with all of the steps in a pattern. But in this particular area, we go through and we think about the solutions, our experiences, the patterns, what's happened in the past, what the dilemma might be, and how we can recognize that pattern and work through it. We had a cardiac surgeon that did some work with us in our education department when I was at St. Vincent's in Melbourne, and we asked him to teach junior doctors knot tying. Worst thing we ever did, because he does multiple knots every day. And he would explain to the junior doctor the step-by-step process. But what he was doing was he was explaining his step-by-step process. And his step-by-step process was often a number of steps combined together to be one step, which may have been for other people 2 or 3 steps. So his pattern of what he did was quite different to the pattern of a novice learner. So we need to consider that in our decision-making and our teaching and learning, how we teach things. Often it's better to get someone to teach a skill to somebody else who's what we would call a near peer. So someone who's at a similar level, but may have a more advanced skill or knowledge level, because they will go through all of the steps that are required to teach someone how to do something. If you get someone who's done, and he talks about how he does hundreds and hundreds and hundreds of knots on a weekly basis, but he doesn't necessarily think about each step because he just does them together. And you've probably all experienced that as a surgical trainee. Someone teaches you something and you've looked at it and you think there's 27 steps. And when they explain it to you, there's 11 because their 27 have become 11. It's the same with anesthetics. When you first look at airway and you're going to intubate and you talk about things, and an anaesthetist, a skilled anaesthetist who's experienced, does multiple things at the same time. And what we do is when we're asking them to talk their way through things, they'll verbalize that. They'll talk about what they're considering in their decision, and the learner can pick up on that. So that's one of the things that we need to consider as we go through and voice our decisions. We also know that recognition prime decision-making models are considered intuitive methods. Clinicians often combine rational and intuitive models when faced with problems or opportunities. So you'll have a preference, but you will combine your decision and look at what it is. So if you have time, you'll take on more information. Some of that information will be hard facts and evidence. Some of them will be things that you've got from an experience type process. I've worked in sport. And one of the things we do in sport is analyze and analyze and analyze and analyze. In Australian rules football, in any sport, most people spend a smaller percentage of their time actually physically training in comparison to the time they would analyze the activity that they do. And what we do often with our athletes is analyze their decision-making processes. So every team sport has team rules. So they decide to play a certain game style, or they will try and expect someone to do something in a certain situation. We spend hours and hours analysing a player's interaction in a game. But we don't spend a lot of time analysing our own interactions in a clinical setting. We will talk about it potentially if something hasn't gone quite the way we'd like it. But when you're seeking feedback from your more senior clinicians, when things are going well, they don't necessarily always give you feedback. they don't necessarily ask you about the decisions that you're making. They don't always share with you the decisions that they're making. But in sport, we often talk about why someone does something. And we do often take a debriefing approach that we would use in our simulation to talk about the action and what it was that led to that particular point that brought about the particular action. How or why you would do something depending on the situation that you are in a game. I watched a little bit of the ice hockey when I first got here. If they think that Australian rules football is brutal, I think they should probably watch ice hockey. It's fast, it's hard, and any sport where you can actually slam someone up against the wall intrigues me a little bit. But whether or not they spend time analysing their play, because it is probably a little less, well, appears to be a little less structured to some of the other sports I've seen, and it's quick. So it would be hard to make decisions. But I would expect that they would spend a fair bit of time analysing their decisions. I would be curious as to how many people would stop at the end of the day, write down what they've been doing during that clinical day and analyse the surgeries that you've done. Probably not that often. When I first started in healthcare quite a number of years ago, there was a common situation where they would say that no feedback was good feedback. When you'd say to a junior doctor, how are you going? And they'd say, I must be going pretty well because no one's thrown a surgical instrument at me. I haven't been told to leave the operating theatre, and I've been allowed to do things. Things have changed. People get a lot of feedback, and we do try to talk about the decisions that people are making because it's part of the learning process that we go through. So when we make and analyse our decisions, we want to talk about the situation, because the situation and the assessment that we're making of the situation will have an impact on the type of decision. You inadvertently, when you see a patient or when something's happening in an operating theatre, or you're going to prepare a patient to be anaesthetised, you look at the situation and you weigh up risk. You, as an anaesthetist, would think about the sequence that you will undergo if you can't intubate, how many times you will try, what the next step will be, what the next step will be, and what the last step would be. And you would voice that to everybody so that they all knew and that what you needed would be in the room. When you make your decision, you generate options, you select your course of action, which is really important to explain to someone. Because in a crisis, when something goes wrong, you've probably all been in a situation where you think, I wish they would just talk to me about what's happening. Psychologically, you can't do that. Part of the brain that would allow you to speak in a crisis actually shuts down to free up cognitive space for you to be able to do what you need to do. So when we expect someone to be able to talk to us when there's a crisis going on, it's actually really difficult for someone to do, which is why voicing to someone what you would do in particular situations before you start the surgery, talk about what you're expecting to encounter. And if things don't go the way you expect, what the plan might be, so that everybody's aware and that there are things in the room that are available to you should that situation occur. If it doesn't occur, it's fantastic that you don't need it, but at least it was available. And everyone then knows what the plan would have been. And then you implement, and most importantly, evaluate and think about what we've been doing. So when we make our decisions, we know that there's a big situational assessment that occurs, and it can be instantaneous. We think about whether we've got a low risk situation and we have high time, a large amount of time to make the decision, or a high risk, low time, low amount of time to make a decision. We often have that fight or flight experience so we've got fight, flight, or freeze, where you just don't do anything. I tell the story a number of years ago when I was doing my doctorate. I was walking down the street in one of the side streets, and where I was at university was sometimes not the most fantastic area to be. There was some public housing quite close, and there was a fairly high level of crime. So I'm walking to the car, minding my own business, and as I'm walking in the opposite direction, there's a female walking towards me, and a male runs past her, grabs her handbag, and keeps running down the street. and I think without thinking, and maybe would I do this again? Probably not, but I was significantly younger than I am now. I grabbed him and stopped him and threw him up against the wall to grab the handbag. Is that the right response? I'd probably recommend against it. The interesting thing about it was that in the doorway further up, which I didn't realise, was actually someone with a camera, and it was a couple of university students, and they were recording something for uni. So I didn't realise that it was all put on. Okay, so I've grabbed this poor gentleman, thrown him up against the wall to grab the bag back. They thought it was hilarious. They thought it was fantastic. I made what I thought at the time was an analysis of risk. I didn't think there was that much risk because he didn't look like he had anything that was potentially going to hurt me. Would I do it now with experience? Probably not. I'd probably try and take a photo of the guy so I could give it to the police to try and track him down. I don't know if I would necessarily intervene. So we make decisions based on our experience in the situation that arises. When we make these decisions, we come across kind of that 4 paradigms depending on how much risk and the amount of time we have. So when you've got a significant amount of time, there's low risk associated with what we're doing, we usually come up with creative options. I heard yesterday of some fantastic initiatives that are happening through the Simulation Centre and the innovation work that's occurring, where there's structured creative opportunity. When you're posed with an issue in an operating theatre or in a clinical situation and you can plan for it, then you often come up with a different way of approaching things that would be an appropriate way to potentially fix that problem. Whereas the other absolute opposite end, when you don't have a lot of time, there is high risk, we rely on our pattern recognition because it is familiar, it's proven, and it's usually evidence-based. When we've got our little section in the middle, which is kind of more the unknowns, we have rules, and we all have personal rules. So people who have been working clinically for a long time create their own personal rule set about how they're going to make decisions and about what they'll do. When you talk with clinicians at various stages of their career and they'll talk about how they would approach a case, they've all got little different ways that they would do it. They'll end up with a similar outcome, but they may approach it slightly different because of the rules that they may have created within their own structures. And again, that analytical one where you're going towards that more low risk, high time, where you look at different options and you plan things out, which is why, and I'm a slight advocate for it, simulation's fantastic because you can go through and practice the different methods that you would use to then collect information and data, because I'm a bit data driven, to try and make a decision about what the best way forward would be. Why would you do it? And you can come up with a plan and practice the plan and see what it looks like before you may need to potentially put that plan into place. So when we come through with our decision-making, our creative, there's no rules. You'll go through and you'll work out how you want to do something. It's usually for a new and unusual situation. It's high risk. There's high risk of failure, but you're not necessarily worried because it may be the only option you've got left. With our analytical, you'll compare, you'll identify problems, and importantly, you need to evaluate options concurrently so you can work out what the best thing is to do. Our rule-based procedures, again, learn to develop rules, recognise the situation, apply the rules and the information to that situation. And our recognition primed is our pattern match, which is often our expert situation assessment based on experience, where they can walk in and work out what's going on with a really small amount of information over a short period of time. So where does that work with how we think? So our cognitive continuum, when we're going from creative to recognition primed, we'll think about the amount of memory that you require. So our recognition primed, we'll get it, we'll go through our memory and we'll work about how much and what the expected outcome is really quickly. So depending on the type of situation that we're presented with, will have an impact on the amount of working cognitive space that you need. Operating theatres are very busy places. There's lots happening, lots of people, lots of decisions being made. And one of the most important things to do is to create a shared mental model. So what is it that you're trying to achieve? What is the common goal? What is the understanding? To do that, you need to share your decision-making and your thinking processes. You need to talk out loud about how you're doing something, why you're doing it, how it's progressing, and think about what the impact might be. One of the things that we know within resources is that they will break it up into time. They'll talk about what's just happened and what the plan is going forward for the next 5 minutes. What are we planning to do? When you are doing surgical procedures, it's broken up into sections and you'll work your way through that. It's important to talk about what you've just done and what you're planning to do in the next section out loud, so that the anaesthetist, who's doing a great job on the other side of the drape and, you know, is working away, knows what you're doing so that you can have a two-way conversation. We did a simulation quite a number of years ago where we had a surgeon and an anaesthetist, and we had a range of people from an Asian country. And there was a conversation between the anaesthetist and the surgeon about how much longer the case would go, so that the anaesthetist knew what they needed to put in place. The visitors who were there were mortified that the anaesthetist needed to speak to the surgeon, and that the poor surgeon had to tell the anaesthetist how much longer was going to happen, they were going to go, because the anaesthetist should have known. And in their cultural background, they should never have needed to have that conversation. Whereas we would hope that there would be a two-way conversation. Our thought processes would be shared, our decision-making would be shared, so that we have a shared mental model and a common understanding of where we're at. So the other thing we need to think about when we're making decisions and working our way through things is the cultural background and experience of the people we're working with. You need to understand not just the surgical team that you've got, but the rotating nurses that you may have, the anaesthetic team and what they've got and their experiences, so that we all have an understanding, which is why the timeout before a procedure is really, really important. I went in to have a small procedure quite a number of years ago. They knew what I did for a living. We were there and they came and did the timeout next to me and wanted to have a discussion with me about it. So I knew what was going on. I wasn't quite sure if that was their normal practice, but for whatever reason, they thought that that was a good idea to do, so that everybody understood what the situation was. We're going to watch a small little video, and I think it's a good understanding of shared mental models. So what we're trying to achieve. Now, I will say, and I do know that Dr. Fried is a very big tennis fan, and he may remember there was an Australian tennis player and her name was Jelena Dokic. And she had a rather precocious father who was quite difficult. And if you do Google it, he looks exactly like the particular person in this video. But this is a great example of people who think that they're on the same expected outcome. They get an outcome, but it may not necessarily be what they expected to have. So we'll see how this goes. Fantastic example where someone sees something, thinks that they're trying to achieve an outcome, decides to contribute to it, but it's not necessarily the expected outcome. Because there's one thing that they don't do there. They don't talk. They look at each other, they communicate through body language, but they don't actually talk and work out what it is that they're trying to do. And I'm sure many of you have been in situations where you've walked into a room, someone's expected you to do something, you've started to do it, but you may not necessarily have known exactly what it was that you were trying to do or what they were expecting of you. So there's some things that we need to do around sharing our decisions, sharing our expectations, thinking about our expected outcomes so that everybody in the room knows what it is that we're trying to achieve, and having a shared mental model. So the other thing that we've found really quite interesting is around professional decision-making and ethical decision-making, and trying to voice those thoughts. And there's a bit of work that's been done in Canada, and we use it a fair bit with the College of Surgeons in Australia when we're teaching more junior doctors around decision-making. So we think about making our decisions, and when we make our decisions, and especially a professional clinical decision, again, coming back to adequate knowledge, do you have adequate knowledge and skills? Are you completely aware of the situation? Is it objective, the decision that you're making? And what's in the best interest of the patient? Which is a really important thing to do. We often talk about, and COVID has been one where, like many countries, Australia has had significant impacts on elective surgical lists. In Victoria, which is the state, or what you would call, I suppose, your province, we have at the moment around about 85,000 on an elective surgical list, which we think is significant, but from what I can understand in other places, isn't that significant. But our workforce is, like others, completely under pressure, and we're trying to get our way through things. A lot of training programs in Australia are based on volume of practice and time. So not necessarily competency-based approach. So people have to log the number of cases that they do in the time allocated to them. So there's pressure at the moment to make sure that you do your cases or you have your experiences, because like everyone, they want to progress through their course. They want to make sure that they finish their training within that 5-year period. So we're starting to hear of people who are being involved in procedures or procedures that may be occurring that maybe really in other times may not have been undertaken. So when we think about our decisions, there's a fantastic paper called First Do No Harm, and it looked at surgical, it's specifically around surgery, and it looked at 39 academic surgeons and from different specialties across 4 hospitals associated with the University of Toronto. And the reason we were drawn to this one is Carol Ann Moulton, the last author, she was Australian. She went to Melbourne University. So we couldn't help ourselves. We kind of got drawn to the Australian who came to Canada and never came back. It's really interesting because they come up with classifications for their decisions. So they have avowed decisions, unavowed decisions, and disavowed decisions. And within that, they really categorize them as patient-centered, system-centered, and self-centered. And depending on the situation that you're in, will often depend on the type of decision that someone makes and whether or not they're happy to share that. So I've just been saying that we want you to share decisions, share your thought processes, because we want people to learn about the processes that you're going through and the way you're treating. There are some of these types of decisions, some of them you're not going to share with people. So I'll give you a scenario. We've got an 80-year-old woman with a diverticular abscess, and the decision's been made to resect the colon. She makes a strong plea that a colostomy be avoided. And she's a private patient. So we're going to operate on her privately, not in the public system. We have 2 different systems, private and public. So in the public system, the government funds the surgery and the hospital stay. In the private system, you would fund it yourself, or you would go through your medical insurer. So she's asked not, she's really put up a big argument not to have it. In an avowed decision making, there's the fear of doing harm, and you're thinking about what's in the best interest of the patient. So this is where you think, and if you do the colostomy, and you had to do the colostomy because there was just too much infection, and I was concerned that an anastomosis would fall apart and the patient might die. So you're happy to explain that to the patient and the patient's family because it was in the best interest of the patient. You'll explain that to the juniors or the people who are working with you because that's the right thing to do. And that was in the best interest of the patient. So it's a very patient-centered decision. And people then understand the logic and the decision-making and the thought processes behind it. An unavowed decision where we consider our colleagues and what's happening around us, the system pressures that are occurring, potentially the teaching pressures that you're under, and the time pressure. And I did the colostomy because I had another case to do with cancer on the list. And if I did the anastomosis, that case would be cancelled. So you've made a decision to do something because of the system pressures and what may be in the interest of another patient and trying to get someone through. Who would you talk with this about? You would probably not necessarily tell the patient, but you'd talk to your colleagues probably when you're complaining about the pressures that you're under and why you do things. And people start to understand not just the clinical decisions you make, but the systems pressures that are placed upon us when we're making those decisions. And a disavowed decision. So concern for personal image and reputation. Often ego and overconfidence will drive those decisions. It's based around hierarchy. And it's usually, or often, I shouldn't say usually, often got a monetary motivation. So the situation may be, I did the colostomy because she's a private patient and I would get another fee when it is her time to come and close the colostomy. It's the same as, or similar to people who have angiograms. And we had a big issue in Australia with angiograms and angiography with cardiologists without real definite reasons to do it. But that was an investigation that we would do just to make sure that everything was done. But there were probably a number of other investigations that could have occurred before we got to that point. So there was a real monetary value driving some of the decisions that we make. That's not necessarily why people should or would go into healthcare and medicine. There are financial gains to be made, but it should be about the patient. But it's not always about the patient. So, in conclusion, the importance of sharing our decisions, there are a number of them. One is to teach and learn. So if we're sharing our decisions, if we're talking about our thought processes, we're verbalizing our thought processes so people understand, others will learn from us, we'll reflect and evaluate on our own thought processes and where we're at with our decision, but we'll also have the opportunity to learn from others too, because we'll create an environment where people will share their decisions and hopefully, not always, but hopefully in a professional, respectful manner, we'll start to be able to question you on things and be able to think about what's in the best interest of the patient. It will help us create a shared mental model as to what we're doing and why we're doing it. And we would hope will improve patient care and patient safety and patient outcomes. So I'm happy to take some questions.
Rob, thank you for a fantastic talk. I think it stimulated a lot of thinking, and I just wonder if anyone in the audience wants to share their mental model. Let me just bring you a microphone. So people on Zoom. Yes. Question.
Hi, I'm one of the chief residents here in general surgery. I just have one question that I know I experienced as a junior resident, and I think I still see junior residents doing that when I'm walking them through cases, is we're often hesitant to ask why an attending is doing something in particular. And everyone has a different style of teaching, and some attendings are more open in discussing and really talking through the cases as they're operating, whereas other attendings just do it and then they'll explain it to you later. So we often run in those cases where a junior will say, well, why did you do this? And then the attendant will say, well, why are you questioning me? And how do we try to make it more mainstream or more try to implement that more on a regular basis? I like to talk through cases as I'm doing them, and sometimes it's annoying to people around me, but that's how I walk myself through the case. And I hope that junior learners get something from it. And it also helps the attending who's maybe just sitting on the side or watching me operate understand where I'm going and that I'm not just doing something that's potentially dangerous. So how do you suggest that we overcome that?
And I think it comes down to the culture that you create and that of education. So encouraging senior people to talk about what they're doing and encourage them to ask for input and question. But it takes time. So people often talk about psychological safety. And, you know, I used to turn around and say, oh, this is a psychologically safe area. This is a safe environment. You can talk about whatever you like. Well, it may have been for me because I wasn't necessarily under threat, but it wasn't for the people who are asking questions. Safety and psychological safety is decided upon by the person who is in that questioning position. So what we are hoping to provide or produce is an environment in which the attending may feel that they're not being questioned around their clinical decision, but they're being questioned around why and how from a learning perspective. So one of the things I often say to someone is ask it from a position of curiosity. So just say to someone, I know, and it's an advocacy inquiry type debriefing approach where you say, I noticed that you did this and I've never seen that before, or I'd like to learn about it. I'm curious, could you explain it to me? Could you explain why you do that? Because I'd like to learn how to do it. So it puts them in a position where, and I've had it done to me a couple of times where you think, oh, I mustn't be too bad at this, because they're asking for my opinion on how to do it because they want to learn from me, rather than, oh, you know, I noticed that you did that. Can you tell me why you did it? It sounds like you're questioning somebody because they're potentially done the wrong thing. Whereas if you pose it to more of a curious learning type question, then they're more likely to see it that way and potentially share. So it's the culture that you create.
I see there's a question from Deborah Sarah. Do you want to turn on your mic and or you could read it in the chat if you wish, Rob?
So Deborah said, how might we use this model to change how we do things as a medical team in a situation that might require some quick decision making? Perhaps the team has been doing something the same way for a long time, but there are better or safer ways that than what seems to be the norm. So, and I was talking about this yesterday in a situation in Perth where there'd been a resus and they were treating a patient who they thought was going to have a fairly negative outcome. And one of the things that we try to encourage and in an emergency department is the leader would stand at the end of the bed and have a real hands-off approach and direct, take the information in, give some thoughts about what their plans are, and really be a director and a leader rather than someone who's hands-on. And he was talking about what he thought the outcome was going to be and what the process was. And he then encouraged everyone to ask and give their input. So what we need to do is when we're thinking about how we work our way through a situation, we want to ask, and as a leader within that environment, we want to ask people if they've got a thought. This is what I'm thinking of doing. Don't ask if everybody's happy about it, because often they'll just say yes. What you want to ask is, has anyone got any other ways that we might be able to approach this? I'm open to your ideas. And get that information and then make a decision. And you might say, actually, I'm going to continue with what we were planning, but at least we have a second option now if things don't work out. So it's about how we ask our questions as leaders to try and encourage people to give their thought processes, because it's true, we do things over and over the same way all the time. And that often happens when we've got stable teams that we work with all the time. We go in, we know their capacity, we just get on with it. They are the more dangerous teams because we take things for granted. The ad hoc throw together team, where we have to work out what people can and can't do, and we'll ask each other about their experiences, and we will go through and not necessarily do the same thing all the time, opens up that conversation as well. So I hope that gives some sort of answer.
I was just curious, you were talking about rational and intuitive decision makings and shared mental models, but these are disseminated through trainees through the apprenticeship model. How would you propose maintaining continuity and uniformity across departments and institutions while being in accordance with best evidence practices?
So, the best evidence practice, I suppose, is partly the rational model. So it's the data collection, and there's probably no easy, I suppose there's no easy answer to that one. But that continuity of care and the model that we adopt for the care of the patient is often going to be a mixture of our two decision-making processes, but it really does come down to the shared mental model. So it's the shared mental model as to what the patient wants as the outcome. What we think as a treating team is a reasonable potential outcome, because what they might want and what we think we can achieve might be different, and having that common ground and understanding, taking on all the evidence that's available to work out whether or not we think we're going to be able to achieve that, and applying that to the situation that we're in. And if departments do that, and we have multidisciplinary meetings where we talk about the patient and we take that into account and think about the information that we've got, so that we're all talking about it at the same time, and we've got the patient as the focus, and we talk about our decisions, and there'll be some times where we'll debate, the rational versus intuitive. Someone will say, actually, I've just got a gut feeling that's not going to work in this situation. So then someone else may then, from a different professional background within medicine, may then give an opinion that's contrary. But it's about having a respectful debate. But I think a lot of it comes down to the shared mental model and understanding as to what's achievable and in the best patient's interest, I think. I hope that helps.
I have a question for you, Rob. Yeah. So, one of the things that always mystified me when I was a junior resident was that we would see different attendings do different things in the same situation. And now we are, as you said, we're increasingly focused on using evidence-based guidelines for our practice. But in fact, there is also this in the technical specialties in my hands. Mm-hmm. So for instance, evidence-based care takes large, amounts of data, and it means it averages it out, and then it says, comparing this to this large generalizable groups of people, there is a preference for one action versus the other. But in specialties like anesthesia and surgery, which are to some extent technical, skill-based, in my hands often has an impact in your decision-making. And I think the point that you made about sharing or verbalizing the decision-making, it takes away a lot of that confusion that would happen where a junior resident would observe and really don't understand why one surgeon would want it one way or the other. And I think that's a useful way to express that. There is a question from Catherine Paquet. During an acute situation when there is less time to verbalize everything, what do you suggest we also apply to question our fast thinking process to ensure a slow thinking process also occurs in order to minimize our potential biases?
Yeah, I think it's really important that given the opportunity, we try to slow down. We know that in a crisis and in a really acute situation, we have a tendency to do things quickly and then have to repeat them because we make a mistake. So this is my son's absolute pet hate. He's nearly 14, and for as long as he could probably remember, when he's rushing, I would say to him, if you slow down, you may think it's going to take you longer, but you'll save time in the long run because you'll get it right the first time and you won't have to go back and repeat it. So the real difficulty we have is taking check of where we're at and stopping and slowing our actions and our thought processes. And again, still trying to verbalize those if we can, because if we know that that's what we do and slow our situation down, we're going to end up with a better outcome. But it's a really difficult thing to do, which again, why simulation and placing people in acute high stress simulation situations where you get more immersed in that situation so that when or if it happens to you, you're more prepared for it, and your response, your physiological response, you're not shocked by and you have more control over, will allow you to be able to slow down and get it done and be able to go through that slower thinking process and be able to have a better outcome. So it's about rehearsal and preparation as well. Yeah.
An example may be in a trauma situation. You know, we have a rule-based approach. So we have the A, B's, and C's. We go through it quickly. It helps us kind of focus and prioritize things, and then we do the secondary survey. It gives us time to at least buy time, right, to stabilize the patient. The hour has rapidly come to an end. On behalf of all of us in the departments of anesthesia, surgery, from the simulation center, we thank you for an excellent talk. I think it certainly sowed the seeds for us to rethink the way we practice, and for all of us to set an example by sharing the way we make our decisions with the people around us, to communicate and to show the respect that you mentioned among people across disciplines. I also want to thank the class of 1975 for supporting this visiting professorship, and I wish you all a good day. Thank you.
Thank you.